Hello, Vinod. Are you there?
Yeah, John. Hi, I'm here.
How you doing?
Hi. I think there is another 10 more minutes to start the meeting.
Yeah. No. 12 more minutes.
12 moments. Yeah.
Yeah.
Exactly.
11 minutes.
John, can you please make Sanford also in the panelist? Because Sanford is giving a talk.
Okay. Okay. Sanford's giving it. So, yeah. Let me know about the schedule. Is Paul coming? Paul Andrew Gardner coming?
Yeah. First is Paul Andrew Gardner. Then second is probably Dr. Aipcharian,
Okay.
Dr. Borba, and then Sanford.
Okay. Sanford. Okay.
Yeah.
Okay. Where's your camera there? Can I see you there? Vinod, I don't see you there. Where's your camera?
My camera is on. Can you see me now? Hi, Sanford. Hi.
Wait. I'm sure I can. I just can't find you.
Yeah, I can see you.
No, I saw Sanford now. I just saw him.
Hi, Sanford.
Yeah, nice to meet you.
Yeah, nice to see you again. I don't know. Okay, I'm gonna unpin my video, and it should go to you.
Okay.
Hey, Vinod, are you there?
Hi. I'm here. Hi.
Yeah. Okay, there you go. Okay, it started. Okay, so we have 4 speakers, right?
Yeah, we have four speakers. Yeah.
Okay, I'll basically introduce you, and you just run the show, right?
Oh, sure. Yeah.
Yeah, you like after someone speaks, you lead the questions and stuff like that. Okay.
Yeah.
Yeah. You know, you've done it before. You know what you're doing.
Sure. I can do that. No issues.
So, are you home in India?
Yeah, I am at home.
Okay. Everybody's at home. Yeah, we had a great conference for Egypt. A lot of people. Sam ran that conference. It was, geez, the topic I forgot so quickly. Oh, neurovascular. It's neurovascular. That's right. But a very good one.
John, did Dr. Paul Gardner join this? Can you find Paul Gardner?
Borba hasn't come yet. Do you want to ping him? You want to? Yeah, I'll send him. I'll send him the link. Yeah. I have his contact. I can.
What about Paul Andrew Gardner?
Not yet. Not that. Paul, are you here? Oh, I haven't. Sometimes people slip in. I don't see them. I don't see Paul. So you might want to. He was supposed to go first, right? Well, just think of another
Paul is
order.
supposed to.
And I.
Paul is going to speak first. Let me try to get Paul now.
Are you calling Borba now? Okay, I just sent the link to Borba. Paul, are you in contact with Paul through Facebook?
Yeah, I'm trying to get him.
Okay. Oh, hey, here's Dr. Borba.
Yeah, but I think Borba just joined. Borba's there.
Yeah, Borba just came.
And I think I can see Dr. Ajit also there. Dr. Ajit. Maybe you can also add him in the panelists.
Good morning, Louis. He may have stepped away. Hello, Dr. Shah.
Hi, John.
How you doing?
I'm good.
Can you hear me?
Hey, Dr. Borba, how are you doing?
Fine. And you? Good. Hello, Vin. Hello, Felix.
Hi, Professor Borba. Hi.
Oh, Paul, here's Dr. Gardner now. Okay, Dr. Gardner's coming in, Vinod.
John, you got Professor Gardner?
Yes.
Yeah, just let him in. Hi, Dr. Gardner.
Hi,
Hi.
Professor Gardner. Nice to meet you. Hi.
I'm here. Good to see you.
Nice background.
Thank you.
Paul, let me show you a background I got. It's actually you can put a virtual background. I mean, you can put a video in your background.
Oh, really?
Yeah. Let me try to show thee here. Okay, there we go. Well, yeah, I could actually come in here because we have to arrange before this conference starts. We got to teach some disco. It's funny. Well, it gets better.
I think Dr. Borba already knows disco. So.
Oh, it's good. You can put videos in the background.
I should know.
Yes, yes.
How are you, Paul?
Good,
Okay,
good to see you.
good, good.
Okay, we got 2 minutes, Vinod, okay?
Yeah.
I wrote to Ipe. I'm sure he'll come. Hello, Dr. Parek.
Hi, how are you?
Good. How you doing? Welcome. And Carlos
Welcome.
Villa. Carlos
Yes.
Villa.
I can see Professor Roman also in this panel. John, Roman is also there.
Yeah,
Roman
Roman,
Bochniak
you're
is there,
here,
yeah.
right?
Yeah.
Roman Bozchak. Yeah, he's here. Hold on. He was here. Hope we didn't scare him away. Oh, I was going to ask you, Dr. Shah. I said I can't be at a conference with Dr. Joel's not Dr. No. Dr. Joel's not here, but here he is.
And Dr. Atul Goyal, Professor Atul Goyal is here, John.
Yeah, he's here. Yeah,
Wonderful.
Professor Goyal is here.
he's at every one. Dr. Goyal, Dr. Zoom.
Yes, yes,
Good to see you.
yes.
Yeah, Tool. good
Welcome,
morning.
welcome, Dr. Goyal.
Hi, Paul. How are you?
I'm good. Good to see you.
Everything okay in Pittsburgh?
Yeah, absolutely. Hopefully the same there.
Getting
Are you
soon.
operating today?
No, just relaxing at home.
Good.
In
Okay. Hello, Ipe. Ipe, you there?
Hey,
Hey, Ipe, how you? Good morning. Okay, we're going to start for now, okay?
Yeah.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. Bennett, John Bennett of Neurosurgical TV. We have another Neurosurgical Super Sunday. Approaches to the Petrous Apex Endoscopic versus Open. And I'll let Vinod Felix from India run the proceedings. Welcome, Vinod.
Yeah. Hello, everybody. Good morning, good afternoon, good evening. So whatever it's depending on your time frame. So we have been running a couple of series of lectures on particular areas like cavernous sinus, Petrous apex, CP angle, where we have both open and endoscopic approach discussion. So our basic idea was to get a complete 360-degree anatomical orientation of that region. So today our lectures are on Petrous apex, and we have the pioneers in this region to talk to you on this webinar. And all the 4 speakers require no introduction to this crowd. I hope I don't need to waste my time introducing them because they are well known across the globe. They are the pioneers in this field. So with these words, I would like to first call upon Professor Paul Gardner, the pioneer in endoscopic approach to the Petrous apex and cavernous sinus, to talk you on endoscopic approach of the Petrous apex region. I hand over the podium to Professor Paul Gardner.
Hopefully you can see my screen and
Yes.
hear me okay?
Yes.
Yes, sir, you can see.
Perfect.
Wonderful.
Perfect.
Okay, so I'm going to talk, of course, about what I call the medial transpetrosal approaches or endoscopic intranasal approaches to the Petrous apex. And the Petrous apex and the petroclival region are extremely complex, and they're very challenging to access because of the multiple different neurovascular structures that surround the area and block our access to that area. Here's a view from a standard open approach of the anterior Petrous apex, and you can see all of the structures surrounding it, from the 6th nerve to the 5th nerve to the IAC and the internal carotid artery, as well as the cochlea. So a very complex area to access. But you really have to think about it, I think, from a 360-degree perspective, where it can be accessed from multiple different directions and corridors. And that approach selection or the corridor chosen really should vary by the pathology, but also the goal of surgery. And then that should be determined by the location relative to critical structures. Different pathologies have different goals. If you're talking about something like a cholesterol granuloma that maybe just requires drainage and marsupialization, to tumors like chondrosarcoma, where you want to try to get the most radical resections possible. And then finally, more indolent tumors like a petroclival meningioma, or perhaps subtotal resection with preservation of neural function becomes more important. We'll start with a cholesterol granuloma. This group is probably well familiar with these foreign body giant cell reactions. It's common in the mastoid and the petrous and middle ear, but can occur in the petrous apex. This is a classic paper by Brackman describing infracochlear and labyrinthine and all the open or posterolateral approaches for cholesterol granulomas. And this is sort of the standard infracochlear approach, where a transmastoid approach is performed to get into the cyst, but as you can see, it doesn't provide a very wide drainage pathway. And here's a anatomic study that we did looking at the pathways into the petrous apex from this approach. If you compare that to the endoscopic endonasal approach, it can be much more direct. There's no risk for hearing loss because we're not working around the cochlea or the IAC. And it can create a very large drainage window into the sphenoid sinus rather than a small window into the mastoid air cells. Now, all of these approaches to the petrous apex require what's called a transpterygoid approach. And this can be anything, and this is accessed essentially through the maxillary sinus in addition to the standard transsphenoidal access. This can be an extended antrostomy or a complete medial maxillectomy, both of which have similar morbidity. And you can see here, the more of this bone that's removed, the more lateral the access we can obtain. A standard transpterygoid approach, again, starts with this maxillary antrostomy, and then I'll move through showing the different steps where we manage the sphenopalatine artery, remove the posterior wall of the maxillary sinus, and then finally find the vidian and maxillary nerves and drill out the pterygoid base, which gives us then access much more laterally. We have to understand the pterygopalatine space, and most ENT doctors are well familiar with this, but essentially behind the posterior wall of the maxillary sinus, we have all of the various branches, parasympathetics, trigeminal, and IMAX branches. Here we see the palatovaginal artery and the sphenopalatine, which will lead us into the posterior nasal branch, which lead us into the sphenopalatine artery. Here we can see on the right side maxillary sinus, the entire posterior wall of the maxilla has been removed, and we can visualize the periosteum over the sphenopalatine region. We can then dissect out the pterygopalatine fossa, open this periosteum, and we can start to see infraorbital nerve coming into view. Here we see the infraorbital nerve, and then here we see the IMAX giving rise to the sphenopalatine artery. Understanding this, this neurovascular anatomy is relatively straightforward, but it has to be dealt with in order to gain access here. Now, we don't have to dissect laterally out to the IMAX, but in general, for these transpterygoid approaches, we either stay just short of the vidian nerve or transect the vidian nerve to get more lateral access. Here, for example, is the area that we would remove in yellow. You can see that posterior wall, the maxillary sinus, and opening the pterygopalatine fossa. And then behind that in blue is the base of the pterygoid, which gives us wide access now to the petrous carotid artery. The petrous carotid artery here seen in a Roton picture on the left, completely dissected free. You have to really understand the different segments of the carotid artery from an endonasal approach perspective in order to do safe endonasal surgery. There's the parapharyngeal, the horizontal petrous, the paraclival carotid, and then the paraclinoidal carotid artery. Each one of these has its own anatomic landmark. These are the landmarks that I choose for the paraclinoidal. There's the medial OCR, which is the really the confluence of the optic and the carotid and the sella. And then the so-called medial pterygoid wedge, where the medial pterygoid plate meets the floor of the sphenoid. That's directly in line with the foramen lacerum. The Vidian nerve runs lateral to foramen lacerum, doesn't run to it, and it runs over the horizontal segment of the Petrous carotid artery to get to GSPN. And then finding the ascending or parapharyngeal carotid artery is accessed following the eustachian tube. Here's the basic anatomy after that transpterygoid approach. Here you can see in the top slide, you can see the Vidian nerve going just lateral to foramen lacerum. And the Petrous apex region really is entirely accessed posterior or posterior inferior to the paraclival carotid artery. As we drill through this, we have to deal with the length of the inferior petrosal sinus that is draining down to the jugular foramen. And we have to be able to comfortable working around the paraclival carotid artery. But if you look here from that same perspective, we really have relatively good access to the Petrous apex. Here's with a 0-degree scope, and here's with a 45-degree endoscope. And I'll talk a little bit about what this corridor is. There, just like with open surgery, there are triangles. There's a triangle to access the medial Petrous apex. This is what I think is probably the most useful and largest triangle into the Petrous apex. And that's between the 6th nerve, which enters into Dorello's canal at the petrosal process, the paraclival carotid artery, and the petroclival synchondrosis or fissure. Between these structures, we have a beautiful access into the medial aspect of the Petrous body and the Petrous apex. And that's really the basis for all of these Petrous approaches. Now, going back to cholesterol granuloma, one of my former fellows, Dr. Paluzzi, came up with this angle that if you draw from the lateral nasal wall to the carotid artery and then to the medial aspect of a lesion such as a cholesterol granuloma, if that's a positive angle, then you can just drill directly into the clivus and access really quite easily the cholesterol granuloma. However, if it's a negative angle, like you see here, then there really is the cholesterol granuloma is hidden behind the horizontal Petrous carotid, and that can require some more extensive maneuvers, working with angled endoscopes, drilling out the petroclival synchondrosis, and even resecting a portion or mobilizing the eustachian tube. Here's a preoperative picture of the Petrous apex cholesterol granuloma on the left side. And here are intraop figures. Here we can see the 6th cranial nerve will be entering right here at the petrosal process. And you can see this triangle for access into the cholesterol granuloma. And many tumors fill that fill the Petrous apex, extend the opening into this triangle. Here we can see draining it. We don't even have to expose the left paraclival carotid artery. And here we can see the cavity. And then finally, in the past, we used to place little silastic tubes, and now we placed mini flaps into there. And here's the post-op. And you can see how this mini flap really helps create and turn this into a new sinus. Again, this is understanding the pathology. These do not have to be completely removed, but if you turn this into a draining sinus, it cannot recur. We also compared anatomically the open posterolateral approaches and endoscopic endonasal approaches. And here you can see the drainage windows and that infracanalicular approach that I talked about before really did not provide any access to the superior Petrous apex, so it's relatively limited, but it was suitable for the anterior or inferior portion in most specimens. And so it obviously provides access to the Petrous apex, but again, relatively limited. When we looked at endonasal approach, it was able to reach really all of these areas, with the exception of the posterior and inferior Petrous apex. That's those negative Paluzzi angle cases. In that case, it was able to reach still 90% of the time. But based on radiographic studies on CT, endonasal window was 3 times larger than the infracanalicular approach. We also looked at clinical follow-up. So looking at long-term follow-up, one of the critiques of this is that, well, you have to resect these or you'll have recurrence long-term. So we looked at all the cases that had a minimum of 12 months of follow-up. Here's a case that had undergone an infracochlear approach and a middle fossa approach, both, and it still recurred. You can see a stent here. And here we're opening into it again, into that triangle below the 6th nerve, above the petroclival synchondrosis, and posterior to the carotid artery. So once that's open here, we actually can remove the stent that was placed through an open approach because this isn't really providing any effective drainage. And then we can end up draining the entire granuloma. You can see because of prior surgery, there's some CSF leak. We can even see a branch of 7th nerve coming posteriorly all the way out to the IAC. So instead of trying to do a complete resection, we do a partial resection as much as possible, drainage and then marsupialization. Again, in the past, we used to use a stent, and now we use a mini flap. Here we can see the results of these long-term follow-up. Again, we only use those with long-term follow-up. These shorter-term follow-up did not have any recurrences, but we didn't include them just because they didn't have the longer-term follow-up. You can see typical presentation, and about 17% of them were previously recurrent. Most of these were pure transclavial, but some we did have to do a carotid mobilization, and I'll talk about ways to limit that carotid mobilization a little later in this talk. And then most of these we used a stent, or rather half of them we used a stent and half we used a mini flap, and I think the mini flap has become much more useful. As far as symptomatic recovery, almost 96% had improvement in their symptomatology. Here you can see our clinical follow-up average is almost 90 months. And then we had 2 radiographic and clinical recurrences at mean relapse time of 11 and 42 months after surgery, both of which were retreated with repeat endonasal surgery. Here you can see the complications. Intraoperative CSF leak is really the only significant. There were no other permanent complications and no carotid artery injuries. This is just looking at symptom improvement based on approach and really no difference there. The only difference we did find is that using a mini flap seemed to provide much lower rates of recurrence. And so this really has been not only a much more natural way to leave that pathway open, but also seems to be more effective. If you compare this to that Brackman study, it really compares relatively favorably. You can see here the recurrence rate is favorable. The follow-up time in this case is similar. We're looking at 88 months versus 63. And we can see relatively minor complications. The location, of course, matters. The ones that are appropriate for endonasal are those that at least have some reasonable access behind the carotid artery or into below the petroclival junction. And those that are hidden behind the carotid are much more challenging to reach from an endonasal approach. Although, again, I'll talk about another way to access these. So I think this marsupialization with wide endonasal drainage can be an effective low morbidity procedure. And it seems to have a very excellent long-term ability to control recurrence of these. And therefore, I think is reasonable and probably perhaps even should be a favored approach for many of these lesions. Petroclival region can be a little more challenging, and you have to extend down below the carotid artery. Here's a cranial-based chondrosarcoma with a classic location here, beginning at the petroclival synchondrosis. But again, working from that same triangle, here's that same Petrous triangle between the petroclival junction, the carotid artery, and the 6th nerve. And here we're going to work up behind the 6th nerve, peeling tumor off the lateral posterior fossa dura, lateral clival dura. And you can see how the lesion really starting to, the chondrosarcoma is starting to evacuate itself almost. We have access to the Petrous apex. We can open lateral to the periclival carotid artery to gain access here for some tumor that's around the horizontal segment of the Petrous carotid artery. Here we see the Petrous carotid artery going laterally. There's tumor extending into Meckel's cave. And now releasing and mobilizing more, this foramen lacerum gives us even more access out to the Petrous apex. Now we would do what's called a contralateral transmaxillary approach to gain access here, but here we had to mobilize the carotid artery. And then finally working just behind the 6th nerve as it enters Dorello's canal at the top of that medial Petrous triangle. We now have access all the way into the Petrous apex. Here's using an ultrasonic aspirator to access and drill out the Petrous apex or resect any involved bone. And then we're resecting any involved dura to make sure that we have a complete removal. There we can see the 5th nerve. We're running below the 6th nerve through this triangle, but we have access all the way out to the Petrous apex and almost to the IAC in this particular case. And here's the post-op, which shows a complete resection of this tumor. And you can see how we've accessed almost all the way out to the IAC here, drilling out the Petrous apex. For chondrosarcomas, we had 35 patients, which required some of them more than one surgery. And a lot of that has to do with, many of these do require open procedures. And so, endonasal and open approaches to the Petrous apex, in my opinion, are complementary. And it's simply understanding what's your goal of surgery and which ones you can access. Gross total resection was achieved in about 2/3 of cases, which of course is the goal in all of these, but many chondrosarcomas can be indolent and a small residual will not regrow. So where did we leave residual? Very large tumors. If they involve the middle cranial fossa or cavernous sinus, those might be areas that we either wouldn't want to resect or don't have as good access to. And then the cerebellopontine angle obviously is better accessed through an open approach. Many of these, as a result, we staged them. Again, out of these cases that we treated, 6 of them required an open procedure as part of getting a radical resection. As my friend Jacques Morcos would say, craniotomy is not a bad word. And again, the same areas, inferior and lateral areas often require an open approach combined with endonasal approach. So it's a great midline corridor, but inferior and lateral tumor access requires an open approach. When we had recurrence, some undergo resection, others undergo retreatment. Here you can see a very large mesenchymal chondrosarcoma that repeatedly recurred. The patient was non-compliant with follow-up with radiation, and so we'll just come back whenever he had a large recurrence. We did have 3 deaths, one from metastatic disease and one from unclear stroke-related etiology. Even more controversial, petroclival meningiomas. These come in several different varieties, and certainly I would never propose that all petroclival meningiomas should be done endonasally. Again, these are petroclival. This is a Petrous meningioma and not at all the same type of tumor. This obviously is easily accessed through a retromastoid approach. But petroclival tumors, which are medial to the 5th nerve, many of these, because of their medial location, can be accessed endonasally. Here you see a case where we resected everything, but the portion that was stuck to the 6th nerve. Again, the 6th nerve really is a limitation, really from either approach, open or endonasal approach. Many of these require pituitary transposition. When we first began doing them, we would simply pull up the gland and try to pull down the dorsum sellae and the posterior clinoid, but you can see that's somewhat of an uncontrolled maneuver. Since then, we came up with, and Dr. Fernandez Miranda did a beautiful job describing a trans-cavernous posterior clinoidectomy, where we do an interdural approach. We can coagulate and cut the inferior hypophyseal artery, which doesn't have any long-term consequence for the patient, and resect the posterior clinoid. Here we can see the right posterior clinoid being resected, and this indeed gives us access behind the pituitary. So a tumor like this, where it seems impossible to resect the upper pole of it, by removing that bone and using an angled endoscope, we can reach upward and dissect the tumor down safely from the interpeduncular fossa. We can dissect from PCA and SCA in the 3rd nerve. Here again, we see that being done on the left side. This trans-cavernous approach to resect the posterior clinoid. This maneuver can be done safely. I think the trans-cavernous aspect of it gives us very direct view of the posterior clinoid, and I think the extradural version is really not nearly as safe. And this is the view that we get then working with an angled endoscope after resecting a tumor. Here we see the basilar, PCA, SCA, and 3rd nerve. This is tumor capsule, which is adherent to the brainstem. All of us have seen that on a petroclival meningioma, and we tend to leave that capsule and not try to strip it to prevent damage to perforators. Here we see the post-op on exactly that patient, and that small capsule collapses against the lateral residual, decompresses the brainstem, and can provide good symptom resolution. Here's a recent case that we did of a large petroclival meningioma. This is a relatively young man who presents with imbalance and weakness. Found to have a very large petroclival meningioma. Again, petroclival because it's medial to the trigeminal nerve. He's got some mild hydrocephalus, which we treated with a ventriculostomy at the time of surgery. And here you can see the tumor extending up well up behind the sella. So we start this with the sellar exposure, and I'll move through this a little bit in the interest of time, but a very wide sellar exposure. Both paracellar carotid arteries need to be exposed. We need to remove the tuberculum so we can mobilize the sella upward. You can see our nasal septal flap can be somewhat in the way, and so we have to be creative, moving it up to the planum, maybe sometimes putting it in the maxillary sinus. Here's what we call a rhinopharyngeal or retropharyngeal flap, where we preserve the nasopharyngeal mucosa and the basopharyngeal fascia as part of the reconstruction. And then we can do a full clival access. We're drilling out the paraclival and horizontal petrous carotid arteries. Then we drill out the entire clivus. And you can see here, here's that Petrous area. We've completely drilled out this Petrous triangle as much as possible to gain access to this lateral region. We still have to worry about where is sixth nerve. It's the most challenging thing with one of these petroclival meningiomas, regardless of approach. The fourth and the sixth nerve can be extraordinarily difficult to dissect free. So here we start to see some of the feeders from the Petrous carotid artery. We can coagulate and control that. And again, we did this in 2 stages. So about an 8-hour surgery for the first and about a 6-hour for the second, the following day. Just debulked it the first day. And then the second day did a pituitary transposition, an interdural approach. On both sides, opening the cavernous sinus, no pituitary dysfunction from this. We've left drainage superiorly. We've left the superior hypophyseal artery blood supply. We can remove the right and then the left posterior clinoid. And now we have complete access all the way up to the interpeduncular fossa. We can switch to an angled endoscope. Here we're doing the extracapsular dissection, lower down by the vertebrobasilar junction. We see the sixth nerve on the left side. This can be stimulated with a cartouche dissector, just as we would do with an open approach. And then finally, we find it here on the right side, and you can see it completely wrapped up in this tumor. I won't belabor this dissection, but here we can see the third nerve. And again, because we're accessing this from midline, I don't have to manipulate the third nerve. I just have to dissect tumor free from it. Here's our final view. We can use ICG to make sure that the perforators are all intact and look at our flap even. So here's our final resection where we're able to preserve the sixth nerve. You can see it running up laterally. I think we have a better view of it in a moment. And of course, he had a transient sixth nerve palsy, but this improved over time. And here we see the post-op MRI. Again, we've left a small amount of tumor towards the Petrous apex, but completely decompressed his brainstem with no long-term deficits. And that could be resected through a retrosigmoid approach. I'll skip through this in the interest of time. This was our early experience with endonasal versus retromastoid. But to summarize, we didn't get radical resection and no gross total resections in anything but about 15% of cases. But our goal of resection was trying to improve the patient and minimize complications. Here you can see a trade-off between sixth nerve palsies and more lateral palsies with an open approach. But the most important aspect of this is that with this approach, we were able to dramatically improve Karnofsky scores in a very short time. So most of the time, if you look at petroclival meningioma studies, the Karnofsky score decreases in the first year, where in these cases, it actually increased relatively rapidly. So I think these require different approaches depending on their extension, and many of them require open and endonasal approaches. If the majority of the tumor is medial to the neural foramina, then an endonasal approach I think is ideal for it. And if it's lateral, then an open approach would be much better. Reconstruction has to be planned so that the flap is on the opposite side of the Petrous apex. And of course, the risk of carotid artery injury in these cases goes up dramatically. Here's a Petrous carotid artery having to be sacrificed during a chordoma resection. Fortunately, from collateral, there was no consequence to this. But again, I can't emphasize enough the importance of understanding the anatomy of the Petrous carotid to avoid injury to it. To finish off, I want to discuss a new approach, a contralateral transmaxillary approach that we recently came up with. Dr. Schneiderman came up with this approach. Coming from the contralateral maxilla gives us a perfect trajectory right down the petrous apex behind the horizontal petrous carotid artery, and gives us much more lateral access through that medial triangle into the petrous apex. Here you can see the difference in angle that it gives us, and gives us much more radical ability to resect laterally when you think you wouldn't be able to through a transsinus or an anterior approach. Here's a chondrosarcoma where the CTM gave us beautiful access into the petrous apex all the way out to the IAC. And here's an example of, here you can see, we should show the preoperative films. I'm going to skip ahead. Here's the transnasal portion of it with the clivectomy, exposing the foramen lacerum and vidian, dissecting the petroclival junction, and then starting to remove tumor from the medial petrous apex transnasally. But you can see we can only access so much from that corridor. Now going from the left maxillary sinus through medial maxillectomy into the right petrous apex, now my instruments can reach completely behind. Here's the horizontal petrous carotid artery. You're looking out laterally with an angled endoscope, all the way back to the peripharyngeal segment of the carotid artery, all the way down to jugular tubercle, cleaning out the entire petrous apex from the IAC down to the jugular tubercle. Very radical access to this, and a wonderful new addition to our anterior corridor. We've done this in about 29 cases and able to get gross total resection of the petrous tumor in about 73% of the tumors. Most of the time, side note, we do place the nasoseptal flap on the same side as the CTM. Now, endonasal versus transcranial, it's important for us to understand how they fit together. We looked at how much volume of the petrous bone and petrous apex can be resected through a standard open approach to the petrous apex versus different endonasal and CTM approaches. And of course, everyone here is familiar now with both of these approaches, or will be by the end of this. And the CTM, it turned out, really got us the most dramatic access to the petrous bone and the petrous apex. We use 3D CT reproductions to understand this, and you can see the Hakuba doe length for the petrous apex and the CTM gave us the best access. Very similar, but for the petrous body, the majority of the petrous bone, the CTM, the contralateral transmaxillary, actually gave us the best access to the majority of the petrous body. So for overall access to the petrous bone, the petrous apex, Hakuba doe length is beautiful access to it, but the CTM can reach that. And then for the petrous body, the contralateral transmaxillary is probably the most superior access to the petrous body. So in conclusion, I think endoscopic endonasal approaches provide a novel way to access lesions in the petrous apex and the petroclival junction, but they do have a novel set of complications and a very long learning curve. I think as long as lesions are primarily medial to the neural foramina, this provides excellent access. But remember that these petrous apex approaches really need to be tailored to your expertise, as well as to their location relative to the neurovascular structures. These should be the primary determinants of approach. Endonasal and transcranial are very complementary approaches. Here's a woman I did just this past week who initially I had recommended to her that she undergo an anterior transpetrosal approach because she had concern about about pregnancy, and I didn't want to affect her pituitary function. But she very much came to me specifically for an endonasal approach, and so switched to that at the last minute. And here's our post-op with, again, you can see some residual out at the petrous apex, but completely decompressed her brainstem, and she only has a partial 6 nerve, which I'm certain is going to recover. Again, surgeon experience is critical. You can't start with a transpetrosal approach, even through open or through endonasal surgery. And here you can see our slow learning curve over the first portion of our institution developing these approaches. Craniotomy and endonasal really are complementary. We're still understanding where endonasal approaches fit, especially for regions like the petrous apex. But I believe that they're very complementary. There's not one approach for any tumor, and understanding and being able to perform both at the highest level allows us to offer our patients the best options overall. I also want to invite everyone to join the Skull Base Congress, which is a free educational website, has much of this anatomy on it, and is also an open forum for discussion for skull base surgery. Thanks again for including me in this Congress, and I'm honored to be part of the panel.
Professor Garner, there's an excellent lecture. Fantastic. We really enjoyed each and every bit of that. And maybe I should ask you to take another 5 minutes and play an unedited video, or a grossly edited video of a contralateral transmaxillary approach. Is that possible, Professor?
I'm sorry, what's the question?
Can you take another 5 minutes and show us a contralateral transmaxillary approach to Petrous apex?
Yes, of course. Let me. Yeah, I think that's very important. Let me go back and go through that perhaps a little more slowly.
Yeah, exactly.
Okay, so here, this is the contralateral transmaxillary approach. Again, we published our initial experience in JNS in October, 2 years ago now, when we started doing this about 4 years ago. And here's the basic concept behind it. You can see our trajectory is coming from the right maxillary sinus, from a Caldwell-Luck incision, a sublabial Caldwell-Luck, through the medial maxilla and behind the horizontal petrous carotid artery. This is simply a matter of angles. If you look at the transnasal trajectory, that puts us essentially in line with the paraclival carotid artery, but has limited ability to reach to the petrous apex without dramatic mobilization of the carotid artery, which is a difficult and high-risk maneuver. So again, working through that triangle that I've described, that's what gives us our access. But when we work through that CTM trajectory, the contralateral transmaxillary, it actually lines us up almost perfectly with horizontal petrous carotid artery, and we can take that all the way back to the internal auditory canal. Here we can see the views that you can get from the different approaches. Here we can see from an endonasal corridor, and here's from a CTM corridor, much more lateral access and much more lateral view. This is the paper when we first described the approach itself. And here you can see the angle relative to the petrous carotid artery from an endonasal approach is about 45 degrees. Whereas from a contralateral transmaxillary, it's only 20 degrees. So it's almost parallel to that carotid artery. And so you can see how this instrument can reach behind the horizontal petrous carotid. And here we can see that CTM. You can see access all the way. This is a chondrosarcoma that involves part of Meckel's cave as well as the petrous apex. And by reaching behind the carotid artery, again, the tumor grows from medial and expands laterally, and that's why we're able to access it. So we're taking advantage of tumors that are growing in a paramedian plane. Here's another great example. So look how this tumor, this chondrosarcoma, is directly behind the horizontal petrous carotid artery. But if you look at the trajectory from the CTM, it puts us completely parallel to the long axis of this tumor. This is the Spetzler two-point concept, where if you line up with the long axis of a tumor, that gives you the best access to the entire tumor. And this is a perfect example of applying that. This was a large chondrosarcoma where we did our transnasal exposure first. So we did a full transpterygoid. We drilled down the pterygoid wedge. Here's disconnecting the eustachian tube from the bottom of that pterygoid wedge. Completely skeletonized the paraclival carotid artery to be able to mobilize it. But then working from the endonasal approach, you can see to be able to access tumor, we have to mobilize it. This is the so-called lingual process being removed. You can see the Vidian canal and Vidian nerve right there, right here. And then the petroclival junction is being disconnected from foramen lacerum. So once I've exposed foramen lacerum, I can see that carotid very nicely. I can start to cut some of the petroclival synchondrosis to be able to mobilize the artery and the tumor. And then working transnasally, I can work somewhat behind the carotid. But coming from the left maxilla, now my angle of approach, you can see how my dissector is coming in. So rather than coming in this trajectory, it's able to come in almost completely parallel to the Petrous apex. So we're going to place an angled endoscope in and look out now laterally towards the horizontal Petrous carotid artery. So here's an angled endoscope. So this is the horizontal Petrous carotid at the top of the screen at 12 o'clock. Here is the middle fossa dura, the back part of Meckel's cave. The IAC is right out here. We're working out below the IAC. You can see how this allows us to remove the entire body of the Petrous. So not just the Petrous apex, which is the part that's hardest to reach through this and best reach through an open approach, but this is very complementary because it gives us access to all of the Petrous body, which would be relatively blind from an open approach without a combined petrosal approach, for example. And you can see here, this takes us right up to the IAC and all the way down to the jugular tubercle. We can then fill in that space really nicely with fat and use a nasal septal flap. And that allows us to get complete removal of many of these kind of tumors that involve the Petrous apex. Here's a recurrent chordoma that was resected using a CTM. We combine it, of course, with endonasal. And again, you can see the radically wider angle of access we have to the Petrous apex for these kind of tumors using a CTM. Again, we looked at this with both our clinical experience to the Petrous apex and also the anatomy in lab, and I found that for the body of the Petrous bone, there was no other approach that came close. And for the Petrous apex, it actually provided similar access as a standard open Hakuba-Dolink type of approach. Hakuba-Kawase-Dolink anterior Petrosectomy. So hopefully that does help explain that a little better.
Yeah, thank you.
It's one of my favorite new approaches because that's an area we always struggled to reach. And we had to do some dramatic maneuvers, and this just changes our approach, our access much, pretty dramatically.
It looks really fantastic. Thank you. Thank you, Professor. Professor Aibcharan, are you around?
I'm here.
So any questions or you want to take over to the next lecture?
Yeah, I mean, fantastic, Paul. Well, my comments would be that for a petroclival meningioma, I mean, I would, of course, I mean, many people don't have your experience and your skill. And with the open kind of approaches, I think it's much more easier and direct to be getting into the to the Petrous apex rather than going endonasal. I really appreciate the transmaxillary approach, but even then, your corridor is going to be really deep and narrow. And so, of course, with the skill sets that you have and their experience that you have, it may be easier for you to get into that. But I would still stick to an open approach, probably anterior petrosectomy or a combined Kawase plus Dolink, which we will be showing right now, anatomy of which we'll be showing right now. But that's my opinion, but because obviously I cannot operate that.
No, I think I think one limitation of the contralateral transmaxillary approach is it's not good for meningioma. It's only good to the Petrous apex because you can't reach posterior from the contralateral maxilla because your flap and the pterygoid on the contralateral side prevent you from getting more posterior. So it doesn't improve your access for a petroclival meningioma, unfortunately, only to the Petrous apex. And of course, the important piece there is, being able to safely do this. And certainly our complication rate initially with petroclival meningiomas was much higher.
Paul, can I make a smallish comment?
Of course.
Well, that was out of the world presentation, no question, no doubt, and no unnecessary, I just want to compliment you for going a line further ahead in this business of skull-based surgery. You know, you have done what I have never actually really seen people doing petroclival meningiomas and going beyond the dura in the Petrous apex the way you have done. What it shows is, what you are showing is, I am getting a feeling that many of these extradural tumors, like chondrosarcoma you showed right in the Petrous apex, I think these extradural tumor, I have no much doubt left now that these tumors can be and probably should be removed by this route. I still have a lot of doubt, and because of my focused interest in transcranial for intradural tumors like petroclival meningiomas, and my feeling is, not feeling, I'm absolutely still convinced that this may not be the best approach. But that is one aspect because of my experience in that route. What you are showing is an alternative view, an alternative line of thought, and you have shown some beautiful results. And what you have to do is you have to do more and more and more and convince the whole world that this is probably the best or the better route. Possibility of doing it is not the answer that it is the best route. It is possible, you are showing. But whether it is best or not, you have to convince in the future with more and more experience from your side, Paul. But still, no matter what, you have done what I could not have believed before I saw your lecture, Paul.
Thank you. That means a tremendous amount coming from you.
Thank you, thank you. And I wish you the best, and I hope, I'm looking for more and more contributions from you. Of course, the anatomy has to be learned.
Yeah.
Majority of neurosurgeons do not know exactly the Petrous anatomy from a nasal perspective that clearly, to be able to drill that area, to be able to dissect in that region, to be, you know what, you were repeatedly saying about the sixth nerve. My feeling is, you look upon it, my feeling is to get the sixth nerve and get the sixth nerve dissected is easier by a transcranial route. Particularly in tumors like petroclival meningiomas and also in chordomas. I'm not sure if I can, let you know what exactly I mean. But as you have mentioned, sixth nerve is the main issue in petroclival meningioma for sure, and even in clival chordomas. You see, clival chordoma, you know what, Paul? I have realized that the sixth nerve, nobody exactly knows how clival chordoma displaces the sixth nerve. From my experience, I have realized that the sixth nerve is displaced on the dome of the tumor. If you are coming from front, exactly in the posterior aspect, it is in the dome of along the dura. What is your experience on how you have found the relationship of the sixth nerve during your experience with clival chordoma? Can you let us know?
Agree 100%. It is pushed laterally and superiorly by the tumor. The challenge is that, many chordomas run between the two layers of dura, and so does the sixth nerve. And so the chordoma can actually grow out into Dorello's canal in that interdural space. But 100% agree, it's pushed superior and lateral by a chordoma. I completely agree. Petroclival meningiomas, it's very unpredictable. That's what makes it difficult.
Also the Petrous carotid artery, as it goes, you see, normally the sixth nerve goes along the Petrous carotid artery, lateral to it, right? But in the chordomas, carotid artery goes anteriorly and the sixth nerve goes superiorly. Did you understand what I'm meaning?
Yes.
Like
yes.
it leaves the company of the carotid artery. Normally it takes the company of the carotid artery, but in chordomas, it leaves the company of the carotid artery and goes in another direction, posteriorly and on the dome.
Yeah, I think at some point where it enters the cavernous, it has to come back to the carotid. But I think what you're describing is that widening of the medial Petrous triangle. And that's exactly what
That's
these
right.
tumors do.
That's
As they grow
that's
out,
right.
they widen that medial triangle. I agree. Yeah, definitely. It's wonderful
Anyway,
to think about these from both approaches and the relationships. That's one of the most important things we can do in all of this.
Well, thank you, Professor Gardner, for the excellent lecture once again, and thank you, Professor Atul Goyal, for honoring us by your presence. May I call upon Professor Aipcharian to go to his next lecture on anatomy and open approaches.
Yeah, we got 4 talks today, so I guess Paul has done a fantastic job. So I'm not going to take much time, so I'll speak with just the anatomy. You know, the Petrous apex from the open, it's a continuum. It's really a continuum from the trans-cavernous approach. So that's what we're going to show right now. So we're going to see, as we had seen last time, that's the first vertical segment, that's the second vertical segment, and that's the third vertical segments. So you have C7, C5, and C3. So these 3 vertical segments are all odd numbers, C7, C5, and C3. Then you have C4 there, and you have C6 there. So they are the horizontal segments. So those are the segments of the carotid. So you have the 3rd nerve, 4th nerve, V1, the 6th nerve coming in from the Doralus canal, V1, V2, V3. You have the infratemporal fossa, you have the Petrous region. So this is a continuum. So the distance between these approaches, whether you are in the endoscopic route or you are in open route, is nothing. So one leads you to the other. So you're just going to show you the craniotomy for an anterior Petrous approach. So we're not going to deal with the sagittal and the axial unlocking here. We're just going to go through this cavernous, trans-cavernous approach to the Petrous apex. So that is the orbit. You have the frontal lobe there, and you have the temporal lobe there. And that is your orbitomeningeal band. And there is your superior orbital fissure. So the true cavernous membrane is preserved. So therefore, you have the cavernous sinus contents, that's the 3, 4, V1, and 6 getting into the superior orbital fissure there. And to disconnect this part, the frontal and the temporal lobe, away from the orbit, you will have to cut the orbitomeningeal band. That's what we're going to do right now. Yeah, once we cut that orbitomeningeal band, you have the cavernous sinus exposed there. That's the superior orbital fissure. You can even drill off this bone if there's a tumor going into the superior orbital fissure. You can drill this bone off and you can get into the superior orbital fissure. You can open it all the way from the globe to the cavernous sinus. But otherwise, you have your cavernous sinus, you have your clinoid process here, and then you are peeling off. This can be just done in surgery, just the way it is this way. There'll be no bleeding at all, as we showed last time, the trans-cavernous approaches. And all the way up to the Petrous, you can do this. All the way up to the Petrous. Very important to keep the plane. That's a clinoid. So you can start off from tailoring this approach for paraclinoid aneurysms, intracavernous surgery, Petrous, petroclival meningiomas, literally everything. You can tailor this. You don't have to do the full approach. You can tailor, if you know this approach, you know that this is a continuum, then you can tailor this and get into what you need. Of course, there are some steps which you cannot avoid. For most of these lesions, starting from paraclinoid aneurysms to petroclival meningiomas, I do the same thing. I don't keep changing. I do the same thing. So you have your clinoid process, they're completely defined out now. So once your clinoid is completely defined, you can take out the clinoid. It's not very important to the Petrous apex, but definitely yes, when you are doing a petroclival meningioma, you will see how important. Of course, taking out a strut is not important in a petroclival meningioma, but definitely clinoidectomy sometimes can be very important to the corridor. So yeah, now we are going backwards. We have defined the optic nerve there, the carotid nerve, carotid there, the fourth nerve there, third nerve there, V1, V2, and V3 will be there. So we have defined that. Then we're going posteriorly now. Same approach that we do for petroclival meningiomas, especially if they are sphenopetroclival. We do it this way. Otherwise, an anterior petrosectomy, if they are not sphenopetroclival, an anterior petrosectomy should be fine. Sometimes you do an anterior and a combined posterior petrosectomy. I remember the last time that Vinod and me had done one of these somewhere in Western India. It was a day-long affair, terrible. The combined posterior. So now we're getting into the Parkinson's triangle as we showed last time. That's a C5 carotid. That is a vertical segment, paraclival carotid. And very soon you will see the sixth nerve. Exactly what Paul was showing, these triangles, I'm showing you from the lateral aspect so that you get a view from both the medial side and the lateral side. And you see that's a fourth nerve and that's a V1. So that is the vertical segment of the carotid. That's a paraclival carotid. And I'm going to hook out that. You can already see the sixth nerve peeping in there. Not that. So I'll be showing you the sixth nerve in a second. Yes. So that is a sixth nerve. Medial to V1, that's the sixth nerve. So I'm going to just hook the sixth nerve and show it to you. Of course, you can't do that in surgery, but yeah, that's the sixth nerve there. So running across the paraclival carotid, that's a sixth nerve. So that's V1, that's a sixth nerve, that's your Parkinson's triangle. So last time we showed you an intracavernous surgery where we went and clipped the meningohypophyseal trunk through this window. So, but you must know that this is a continuum. So the transcavernous approach and the Petrous apex is a continuum in open approaches. So we're going to the Petrous apex now. So once we come back to V3 and we start exposing behind V3, you are into the Petrous apex. You're exposing the region which you require for a Petrous apex exposure. One of the good things you can do in this approach is that you can open the dura and let out the CSF. And believe me, it is much better than lumbar drain. We've done both, and if you do the cisterns or cisternal opening in this approach, you can open the dura in the base, and then you can open the cisterns, and then you can let out the CSF, and you have a very, very good lax brain. So it's very important for in this approach, you need a really lax brain. If you don't have that, you're really going to struggle. So you have the GSPN there, you have the V3 there, that's the Petrous ridge there. So you have the Kawase rhomboid coming in there. So that is defined now. Once that is defined, so you can see the Petrous ridge there. The Petrous ridge we're trying to identify the C6 horizontal carotid right now. So that will be the horizontal carotid there, this way. So that'll be the V3 there, V1 there. That'll be the horizontal carotid. So we're going to show you the horizontal carotid in a while. Yes, so you see this, that is the horizontal carotid, C6 carotid. That's a horizontal carotid. Once you have the horizontal carotid, your Petrous apicectomy is, I wouldn't say no surgery is a piece of cake, but once you have this horizontal carotid, your anterior Petrous resection and the lateral Petrous resection except the cochlea, and even behind the cochlea up to the IAC, you can have a Petrous resection which is much, much larger. Okay, go all the way up to the inferior Petrous sinus. Go all the way up to the inferior Petrous sinus, and you have the cochlea. You may want to spare the cochlea, of course. And this, the C6 carotid is going to dip down to the C7 parapharyngeal carotid. So it's going to dip down in front of the cochlea, anterior to the cochlea. So this entire thing, all the way up to the IAC and even behind the IAC, you can have a very, very large petrosectomy. And cochlea, the good thing about cochlea is you don't want to, you can decorticate it, thereby getting some more space. You can decorticate it. You don't want to enter the cochlea. This is not a good idea. But so that's what we are, we're taking off the Petrous apex right now, all the way lateral to the carotid. The carotid is skeletonized right now. And we're going ahead and taking out the whole Petrous apex. I feel it's a much, much more direct route than going through the endonasal approach. Of course, I mean, Paul can do it, so can Juan and Vinod and the experts there. But for us, this is rather much, much more direct. And because you're seeing from the lateral aspect, and each step from the clinoid, it's a direct approach there. The cavernous sinus is a direct approach. Petrous apex is a direct approach. Of course, the cavernous sinus, I would agree rather with the endonasal sometimes, because you have the nerves coming in your way. This is something that is against the direct approach. And you can see already the IAM there. The IAM dura is coming up there. So we're going behind the IAM, we're taking off all the bone there. So once the carotid is, you know where the carotid is, it's pretty safe for you to drill out this whole bone all the way up to the inferior petrosal sinus. And all the way up to the true Petrous apex. Sometimes what we do is we sometimes drill the V3 right into the infratemporal fossa, and that means you can mobilize this entire complex anteriorly, and you can drill out the true Petrous apex also, along with cutting the ligaments, and then you can take out, eggshell it, and then take out the entire Petrous apex, and that gives you much, much more space. And if you cut the tentorium, clip the superior petrosal sinus, and make the posterior fossa opening, and also make this opening, you have a very, very direct route towards to your petroclival meningeomas. I'm sure Louise and Sanford might be able to show some cases. So we've done all that. Now we are opening. So the fifth nerve, so this is the opening. You can see the vertical segment of the carotid there. This is the fifth nerve we have opened there. That's the posterior fossa opening there. There will be the IAM. So we have not even cut the 10 right now. I'll show you the exposure very soon. So the fifth nerve is freed now. The fifth nerve is freed. That's the first step. So in each of these, you have to free the optic nerve in some cases. Falciform ligament and distal dural ring can be cut. The third nerve has to be free. The fifth nerve has to be free. So these are important steps in skull base maneuvers. Very, very important steps. Freeing the second nerve, the third nerve, the fifth nerve. And then you must remember that the fourth nerve, compared to the third nerve, is going laterally to the third nerve. You see, it's coming along the medial edge of the 10, while the third nerve is going way medial to it. So although it is in the cavernous sinus, it's the same. So now once we free the fifth nerve, you see the exposure now. So that's seventh nerve. That's the seventh nerve. So that is the lateral margin of the posterolateral margin of the pons, and that is your fifth nerve. That's your IAM and this IAM. So you can see the second nerve, the third nerve, the fifth nerve, all the way from subfrontal, the subfrontal region to the third nerve. I can open this entire sleeve all the way down, and then you can see the fifth nerve there. You can see posterior to the fifth nerve, and that would be the approach to the petroclival meningiomas in an open approach. I would still think that this is more direct, and Paul was showing about the PCP excision. Sometimes in a petroclival meningioma, this is very important. So this is how intradurally we used to do the PCP excision. That's the optic nerve, and that's a carotid, and that side would be the A1. So the carotid A1 and the perforatus coming in from there. So you open the dura of the PCP, and then you use a dissector to mobilize the dura away from the PCP under very, very high magnification, of course, and use a one.
Okay, we have a frozen screen, right?
Yeah, I think we lost Stripe.
Yeah, just wait. He'll be back. It's a digital coffee break. He has to refresh that screen and come back. Like, you can't hear me now, right? Yeah, he'll realize that he's off and come back.
Or maybe if there is some delay, we may go to the next lecture by Professor Sanford.
It's up to you if you want to wait for Ike to come back or go ahead. Well, it's up to you, but
I think we can go for the next lecture because it's already, we are running late.
okay,
May,
whatever you want.
Yeah. So may I call upon Professor Sanford to deliver his next lecture, and probably Professor Ike can continue after Professor Sanford. Professor Sanford, are you around?
Yes, thank you. So can you see my screen now?
Yes, we
Yes,
can.
yes.
We can. Yeah.
Yes, thank you for involving me in this Congress. I'm sorry that the problem with the messages from the Dr. Cherian. So I will start my just a short talk on the trans-cavernous approach to petroclival. So by definition, the petroclival meningioma, as everybody knows, that is seated medial to the IAC and posterior to the Gasserian ganglion. For larger petroclival meningioma, usually occupy supracerebellar, supracellular, interpeduncular, prepontine, and the clival regions. So for such a case, the tumor may extend into the supracellular and in the interpeduncular fossa and the prepontine space, and even to the posterior fossa. So for the large petroclival meningiomas, I preferred anterior approach. And we use the trans-cavernous, transtentorian, and transpersonal approach. It combines the advantages of the Lang approach and the Kawase approach to get a wider view to the petroclival region. And from this elevation, as you see, if we do the anterior approach, and there's three obstacles to this region. The first one is the anterior clinal process. You need to remove the anterior clinal process to get access to the cellar and supracellar region. The second one is the tentorium and the posterior PCP. You have to divide the tentorium, remove the PCP to get access to the interpeduncular and the prepontine space. The third obstacle to the petroclival region is the anterior petrous bone. You have to remove the anterior petrous to get access to the posterior fossa. So this elevation just showed, as discussed previously by Paul and Professor Goel, the petroclival meningioma, the growth pattern, usually they enlarge, they get into the cavernous sinus, and they push the sixth nerve superiorly and laterally. So this elevation shows how important that you have to divide the tentorium so that you can mobilize the trigeminal nerve and to localize the sixth nerve, just pushed by the tumor, and within the this ligament is Gruber ligament. So can we do the same thing in the real surgical routine? Yes, later I will show you the video, the case for illustration. But this innovation beautifully show the tumor growth pattern and how we get access to this petroclival region. So I simplify the major steps into three steps to the petroclival region. The first step is the anterior clinodectomy. The second step is open the macroscape and dividing the tentorium. The third step is doing the anterior petrosectomy. By combination of these three steps, we can totally unlock in the cavernous sinus and to the petroclival region. And also, using this approach, as you see in the cadaver, in the picture in the cadaver, we totally expose the whole region in the supracellar and prepontine and posterior fossa. So previously in my talk, I categorized 4 levels of learning curve in cavernous sinus surgeries. For beginners, you have to be familiar with the tuberculocellular meningioma, spheno-rich meningioma, and some simple aneurysms. And up to the level 4, you get more and more experience and techniques. Now you can deal with the complex petroclival meningiomas or the cavernous sinus meningioma. So for each levels, you have to be equipped with different techniques. Like you play the video games, you have more experiences, you gain more techniques, then your level is up. So the critical concepts and techniques of cavernous sinus surgeries is actually unlocking it. What does it mean, unlocking? The most important one, because all the structures sit deep within the center of the skull base. So you have to make all the anatomy shallow. By this way, you have to know how to peel the dura off the wall of the cavernous sinus, just demonstrated by Dr. Cherian. Then, as I mentioned, since the cavernous sinus or the structure surrounding the cavernous sinus is the skull base bone, so you have to removing the bony blocks in the way to your view. For example, like an anterior clinodectomy. And the most important one, that every nerve or carotid artery has a ring-like dura structure surrounding it and where it penetrates the cavernous sinus. So when you open the cavernous sinus, it means now you have to free all the nerves and the arteries from where it is anchored to the dura. Like this picture. The carotid artery, the optic nerve, the oculomotor nerve, when they're penetrating the cavernous sinus through the dura, they're always ring-like dura structures. You have to free all these structures from the ring so that you can mobilize all these vital structures and widen the windows between the vessels and the nerves and between the nerves and the nerves. So you can get access to the deep in these windows. For example, you remove the anticlinoid, you expose the artery, the phospholigament overlying the optic nerve and the carotid, but you have to cut the phospholigament and expose the corner behind the ligament. And in that way, you can mobilize the optic nerve to widen the carotical optical window. And if you are familiar with these techniques, and you can mobilize, you can remove all the ring structures surrounding all these vital nerves or carotid arteries, then you can totally open the, for example, you can totally open the roof or the lateral wall of the cavernous sinus and expose for this, for example, in this picture, you can expose the whole course of the carotid artery by mobilizing the third nerve. So I emphasize again, for the petroclival meningioma at level 4, the major steps, the first one, if you want to get access to the cellular and supracellular region, you have to do the anterior clinodectomy. You have to mobilize the carotid, optic nerve, and oculomotor nerve. And if you want to get access into the interpeduncular and the preponderant fossa, you have to know how to open the Makos cave, to divide the tentorium, to mobilize the trigeminal, to free the trochlear, and remove the posterior clinal, to widen the window to the preponderant space. And also you have to remove the Petrous apex to localize the abducer nerve, to localize the dilateral canals. And also, if you want to get access to posterior fossa, you have to drill out the anterior petrous and divide the superior petrosal sinus and cutting the posterior fossa to get access into the posterior fossa. So for example, like this case, as demonstrated by Professor Cherian, we do the extradural dissection. So usually I localize the superior orbital fissure. You can always find the dural groove just below the superior orbital fissure. So you can make the clear cuts in the dural groove. And also the cavernous sinus wall, actually we have a double layer of dura. I always mention that the dura attached to the wall of cavernous sinus, one is by the meningoorbital artery, the other one is by the middle meningeal artery. So if you cut the meningoorbital artery, you can expose the superior orbital fissure. And if you cut the middle meningeal artery, you can expose the V3. So it facilitates to extradural peeling of the lateral wall of the cavernous sinus. So you push the dura back up and you can expose the V1, V2, V3, and even the Makos cave, the Gazerian ganglion, and anterior petrous. Then, since you get the wider space outside the dura, and as you know, the petroclival meningioma is intradural lesion. So usually we cut the dura along the Sylvian fissure down to the base of the temporal and extend the excision of the dura bilaterally. Now you can turn the microscope to the Makos cave and you open the Makos cave, you can follow the trigeminal nerve down to its entry zone to the brainstem. And this picture show we expose the anterior petrous and we remove the anterior petrous. Then we connected the cuts of the tentorium because it previously already opened the Makos cave. So you can make a dural incision at the base of the temporal. You can expose the tentorium. You open the Meckel's cave, extend the incision down to the tentorium, and you can divide the superior petrosal sinus and keep on the incision or the tentorium down to the posterior fossa, and you can widely open the space to the prepontine and posterior fossa. So later I will show the video case so that you can realize how I do it. Usually after the surgery, patient may have the transient, maybe the oculomotor nerve palsy or trigeminal nerve palsy. But I refer all the patients for acupuncture, Chinese acupuncturists. Average within 6 months, if you keep the continuity to the nerve, usually they are come back. Up to 90% of the patients will come back within the 6 months. So I summarize, if you do the petroclival meningioma, some key techniques. From the beginning, you have to do the durapeeling, anterior clinodectomy, and anterior petrosectomy, and you have to know how to remove all the ring-like structures surrounding the vital nerves and the carotid artery, and widely open each window between the nerves. Then you have to delineate each nerves and free them from the wall of the cavernous sinus, including the sixth nerve. So this case, I will show how I do it. Usually I started below the superior orbital fissure. I can always find the dural groove below the superior orbital fissure. Then I, using the sharp dissection, I keep the cleavage plane between the double layer of the dura. I started from the V1 till the end of the clinal tip to expose the clinal tip. Then I expose the V2. Usually I can inject the T-cell for hemostasis. Then I turn the microscope to the middle meningeal artery. So this is the middle meningeal artery. I coagulate and cut. Then I can expose the V3 and push the dura backward to expose the Meckel's cave. This is the Meckel's cave. And even from the lateral wall of cavernous sinus, you can identify the V1, V2, V3, even the trochlear nerve. But the sixth nerve is within the cavernous sinus. But you can get the landmark from the Gasserian ganglion. Usually the sixth nerve is at the same level of the Gasserian ganglion and just across the carotid artery. Now I go into the clinoid. Usually I identify the optic nerve, sorry. I can identify before I remove the anterior clinoid, I can identify the optic nerve outside the dura. Like this picture showed, sorry, I don't know how to make it smoothly. So as the sucker tip pointed, is the you can find the optic nerve outside the dura, and you know how the optic canal, the direction of the optic canal. So you drill just galvanizing the optic canal and make a eggshell thing. Then you change a smaller drill to remove to make the ACB like a shell. Usually at the beginning, you remove the spinal wing when you do the craniotomy. And if you thinner the optic groove, because the optic strut is usually fragile, so you remove the two attachment of the ACP to the spinal wing, then it become mobile. Then it is very easy to bite the ACP using the rongeur. Then expose the carotids. Now you can continue peeling off the dura and expose the anterior petrous, just preparing for the anterior petrosectomy. And this is the macroscape. This is a gazerian ganglion. Now I cut the dura. In this case, the patient presented with the right eye ptosis, and the tumor is extending into the lateral spinal wing. So I cut the dura, and also I cut the whole temporal dura just surrounding the tumor. And in this way is easy. This is the redo case by, the first one is by other people. I remove the tumor and it's easy to expose the temporal base. And as you see, when I remove the tumor, this is the carotid. As you see, this is the carotid. This is the tumor. The tumor encased the oculomotor nerve and encasing the carotid. So I will cut, this is the dura ring. So I will first step, I will cut the dura ring just lateral to the carotid because I want to free the carotids and the oculomotor nerve. But already, you already removed the ACP. So you can find the normal structure is, this is the inner membrane. So later I will open the inner membrane. As you see, I cut the outer ring and I open the inner membrane. So I can localize the normal end of the carotids. Then I continue the cutting at the point where the outer ring fused with the inner membrane. Lateral to the carotid at the tip of the clinoid, the inner membrane is fused with the outer ring. So you can open the inner membrane, cut the outer ring, and actually you can circumcise the ring surrounding the carotid. So I open the carotid in the, usually this space, within this space is a gland, the pituitary gland. And I localize the pecan, free the pecan of the tumor. And also, now I turn back to free the optic nerve from the phospholigament, and it can facilitate to remove all the outer ring surrounding the carotids along with the tumor. So I cut the outer ring of the carotid and remove the tumor of the pecan, and this is the anterior choroidal. Using the similar techniques for the clinomeningioma. Sometimes the clinomeningioma surround encasing the carotid. Now I free the optic nerve carotid. I turn to the oculomotor nerve. I cut the ring structure, open the oculomotor window. As you see, I open the oculomotor window, and as you see, this is the normal segment of oculomotor nerve, and this is the tumor, and this segment of the oculomotor is bulging out. So this is the indentation. The nerve is strangulate at this point. So now you cut the ring structure surrounding the oculomotor, you free the oculomotor nerve. So this is why the patient developed the ptosis. And now you have to remove the tumor within this is the Parkinson triangle. Now you have to remove the tumor within the Parkinson triangle and release the oculomotor nerve. So I cut the ring. So this is the carotids. And this is the, sorry. So I free Sorry, I'm not familiar with this video player. Okay. I removed the tumor off the within the Parkinson triangle, and I also localized. Can you see this this branch? This is the vascular branch is from the meningohypophyseal trunk. So it means it's taken off from the carotid. So when I do the tumor removal, I always localize this branch, and I can trace this branch to the carotid. So when you remove the tumor, you can delineate, you can confirm the carotid using the Doppler. So this is the carotid. Now you can remove all the tumor off the carotid within the Parkinson triangle. And you coagulate the branch from the meningohypophyseal trunk. You devascularize the blood supply to the tumor. Now you can detach the tumor off the oculomotor nerve. Then remove the rest of the tissue surrounding the oculomotor nerve, as you see, and free the oculomotor nerve down to the takeoff between the SCA and the P1. And also you can see this trunk is basilar. So this window is very good for the basilar apex aneurysm. If you do this approach, you've got very good space for proximal control. Now I turn to find the trochlear nerve. It is usually below the tentorian edge. So I localize the trochlear nerve, but now I have to turn to the Makos cave. I open the Makos cave because I have to free the trigeminal nerve, open the tentorium, then I turn back to free the trochlear nerve. So I open the Makos cave, I cut the tentorium, and I follow the trigeminal, and I cut the tentorium toward the point behind the trochlear. Now I cut the tentorium, and I widely open the Makos cave to expose the Gasserian ganglion. This is the Gasserian ganglion. So I opened the space medial to the trigeminal so that I can mobilize the trigeminal laterally to expose the space between the fourth nerve and the Gasserian ganglion so that I can localize the sixth nerve within this space. So the next step is to free the fourth nerve. Using the sharp dissection, cutting all the tissues off the trochlear nerve so that I can free the trochlear nerve. Then I can widen the space between the trochlear nerve and the V1. And now I turn to the Gruber ligament. This is the Gruber ligament. So all the tumors behind the Gruber ligament, if you remove the tumor behind the Gruber ligament, is safe because don't worry about the sixth nerve. The sixth nerve is here. As you can see, this is the sixth nerve. It is coming from the dorsal canals within the Gruber ligament. So anything just behind the Gruber ligament is safe. Then you identify the Gruber ligament and you mobilize the V1, you can identify the sixth nerve just across the carotid. And it's always at the level of the Gasserian ganglion. So this is the sixth nerve. Now I can remove the rest of the Gruber ligament and clean the tumor. So if you free all the nerves in the carotid artery and free all the structures in the cavernous sinus, as you see in this picture, all the windows are widened, and this is the PCP. If I remove the PCP, I can even get closer, get lower to the interpetuncular and preponding fossa. Usually we do a bony accusa, but in this case, the PCP is fragile, so I can use in the small round jerk to take bite of the PCP and to widen the space to the preponding space. Then if you remove the remove all the group of ligament, you can even free the sixth nerve and down to the brainstem. The entry is on the brainstem. If you mobilize the V1, and at the end of surgery, as you see, if you totally unlock the cavernous sinus, you can see the optic nerve, carotid, oculomotor nerve, trochlear nerve, trigeminal nerve, sixth nerve, and even the whole course, the basilar trunk, up to the basilar apex. So if you're familiar with this approach, you totally unlock the cavernous sinus and the region to the petroclival region. So this case just show how to, using the trans-cavernous techniques, to widely open this region, especially for the large petroclival meningioma. And also, you can see my video on neurosurgical focus. We publish on the neurosurgical focus video for large petroclival meningioma. I think because of time, I just give a short talk, just similar introduce the some key technique and steps for petroclival meningioma. And I comes from Taipei Veteran General Hospital. I did fellowship for almost 2 years in Little Rock at UMass with 3 of my great teachers, Professor Yasagil, Professor Amafti, and also Dr. Krisht. Also, since I'm back to Taipei, for the past 15 years, we have different topics of dissection courses and life surgeries. And as you see, the corner on your left is Paul and Schneiderman. And because of the COVID-19, this year, the course are all postponed to next year. So we will see everyone next year, and you're welcome to Taipei. And I see you again, Paul and Luis Bova, you are also welcome. Thank you very much. And any questions?
Thank you, Professor San, for that excellent lecture. Really enjoyed it. I think Professor Aib Cheren is back. Professor Aib, are you around?
Yeah, but I guess there's nothing much for me to say, because I think we've seen till the last part of the video, and then Sanford continued the same thing. I mean, he just showed how beautifully it can be done. So I think Luis should start off right now.
Oh, well, okay then, Professor Luis Borba, and of course, here is no introduction. We are all waiting for the big man to start his lecture on open approach. So with these words, I welcome Professor Luis Borba to deliver his lecture.
Okay, everyone. Good morning, good evening, good night. I don't know what time is there. Maybe in Petrous is in the morning. In Brazil now is 1 p.m. It's a pleasure to be here, pleasure to talk with us. And very difficult to follow Professor Gardner, our great friend Sanford, in our mental sharing. And I will talk about the one way to reach the Petrous apex. The way that we believe that can be the root for many pathologies, but also, let's see if you can use the control here. Can you see my pointer?
Yes, at the bottom, you can make it bigger, Louis.
No, I'm trying to 1 second here,
Okay.
to use my, I don't know what's going on. Just
We can see your pointer. We can see your pointer.
Yeah, but I have to allow here first.
Yeah, at the
Okay.
bottom, there's an option to make the screen bigger.
No, 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 no. No, to know when you come to this.
Okay, you'll get it.
Okay, now it's okay. Okay,
There you go. Perfect.
okay. Now let's talk about the anterior pretorsal root. Very similar the Professor Sanford just showed. But you see, you have so many ways to reach the area. You can come from the nose, Paul just showed beautifully, showing wonderful dissections in wonderful case. But we as a neurosurgeon learn to understand this area and use the middle fossa as a route to reach something. And sometimes you use the Petrous apex to arrive to the petroclival area, to arrive to the posterior part of the cavernous sinus, or go directly to pathology to have the Petrous apex, like cholesterol granuloma, like chordomas. With the understand of the anatomy and understand of the improvement of technology, you see you can do much more than you imagined before. Today, the endonasal is the great fashion. I remember when I was starting skull base, I was still in the residence, and Professor Atul Go already was a very famous skull base surgeon. The people was doing beautiful approaches, large approaches. It start from the neck and end in the bottom of the head to try to remove a small lesion. Today, for cranial approaches, 90% of the pathology can be reached by pteryginal or retrosigmoid approach. But you need to know the approaches that you use. I'm sorry, Dr. Gardner, but I want to show this. When I talk about meningioma to intradural lesion coming from the nose, I know I saw a very nice case that you demonstrate. But the paper showed that the limitation of the approach are the 6 nerves, okay? You show the nice 6 nerve bilateral, 8.8 millimeters. With the endoscope, looks bigger, look huge tumor. You can reach areas like this one safely. Maybe you can pull back, pull lateral, pull up. I call pull and pray. There is some vessel that are behind. It's possible? Of course it's possible, but it's safer. In our country, maybe in some countries in the world, you have lesion in the clivus like this, like small grapes. But in the great majority of the countries, the tumor in the petroclival area is like this. It's a jump of grapes. And sometimes the tumor is like this, the whole bottle of wines. If you are coming from the midline, you are just bite the tumor in the middle, the compression, I don't know if the compression. You change the possibility to treat and remove the tumor and save the guy to do a very nice and beautiful picture of biopsy. Let's do what's the best for the patient and go around the skull base. I say today that skull-based surgery is not one approach. Skull-based surgery to learn to go around of the skull base. Sometimes come from the nose, sometimes come from the anterior, sometimes come to the lateral, sometimes come from the back. Because these you learn skull-based surgery in the laboratory, in the training, where you go there and do this. The Petrous apex is one of the most beautiful areas that you can use to read something. Can open the posterior fossa. You can expose the middle fossa. You can go to the cavernous sinus. You can go to infratemporal fossa. You can go to the sphenoid sinus. It's one way that you can reach in using the approaches. I'm seeing today many people talking, oh, don't need to learn temporal bone, don't need to learn Petrous approach, don't need to learn anterior Petrous approach, no mastoidectomy. If you go to China, you see this man, 1,546 petroclival area meningioma. And more than 50% he used the Trans-Petrous approach. I think this guy has some experience, no? With 1,546 petroclival meningiomas, he used 50%. We should trust him. It means that the Petrous approach should be done, should be learned, should be used when you need. Professor Kawase found out one area, that's the Petrous apex. There you have nothing there. That you can use this area to reach something. He started with basilar aneurysm. After that, for tumors in the area. In the Asian people, the Petrous apex is very long, sometimes very large. In Latin people, the Petrous apex is smaller and the mastoid is large. Because these, a lot of people in Asia use the anterior Petrous approach very often to reach petroclival meningioma. But sometimes you cannot reach. If the tumor is intradural, below the internal auditory meatus, you cannot reach by anterior Petrous approach. Maybe you need a retrosigmoid approach, maybe you need posterior Petrous approach. Tailor the approach for the case. The area that you can reach for the anterior Petrous approach, removing the Petrous apex for intradural lesion, is the internal auditory meatus, posterior part of the cavernous sinus, mainly the trigeminal nerve, that is the key of the anterior Petrous approach. You open the porum trigeminalis, you liberate the fifth nerve, you mobilize the fifth nerve, medial, lateral, inferior, superior. This way, we use this route here to reach the area. If you ask me what is the trick of the anterior Petrous approach, the trick of anterior Petrous approach is open the porum trigeminalis and mobilize the fifth nerve. We need to study not only the MRI, we need to study CT scan, especially the bone window. You can see the size of the Petrous apex. You can see how much you can remove. You can see the window that you have. It's very important. And the other thing that is important when you do use the anterior Petrous approach is to know if the history the patient had ear infection. If the patient had ear infection, maybe the Petrous apex will be compact, be more difficult. You cannot get the window that you wish. Always when you work around the temporal bone, always when you work around the temporal lobe, we should study the venous anatomy. But this vein of Labbe is very important because you are working under the temporal lobe, but sometimes you have to retract a little bit the temporal lobe. And the window that we are using here is directly related with the venous anatomy. If you have a vein like this, is going to tentorium, maybe you cannot use the anterior Petrous approach because you cannot cut the tentorium. There is a big lake in the tentorium. or you call this the sphenotentorial sinus, you cannot cut the tentorial, you have to change your approach. Because of this, before planning your approach, you need bone window CT, you need good MRI and MRV or angiogram to see the veins, to see the way that you can do the surgery. This is variation that you can have in the anatomy of the tentorial sinus in the temporal lobe. This variation will be very, very important in the planning of the surgical procedure. And this anatomy has to be in your head. And you are using this part here, the Petrous apex. Liberate totally the 5, immobilize the 5, medial lateral, to have this window here. And this internal auditory canal. This anatomy has to be in your head. Not this anatomy only, but also the location of the carotid artery, the V3, the V1, the V2, and the middle meningeal artery. It's very important to have this anatomy in your hand. Also understand this anatomy. You are not exposed this anatomy, but you should know where is the tympanic tegment, you know where is the geniculate ganglion, you know where is the cochlea, and arcuate eminence, where will be the superior semicircular canal. This 3D view of anatomy is essential when you do surgery in the middle fossa. I always say, before do the approach, before open the head, prepare how you close the cavity. This is a very nice paper that's published by Professor Omefti long time ago. See, very nice idea. Temporalis muscle, cut the coracoid process, displace the temporalis muscle superior, go direct to the base of the middle fossa. It's very nice. Anatomical, aesthetical, very, the muscle will come back to an anatomical position. But there is one problem here. How you close the base of the skull? We need a vascularized flap to close the base of the skull. Because this, when you do the surgery, the transcranial approach, as in the endonasal approach, you should develop flaps. You can use the pericranial flap, you can use the fascia of the temporalis muscle, you can use the posterior part of the temporalis muscle to close the cavity and avoid CSF leak. But before opening, you should plan how to close the cavity. I will show you here the way that we do. We prefer to do a little bit large incision. The people is doing a smaller incision now. It's okay, you can go subcranial. But I do a little bit larger to have this fascia. See? Here is the superficial temporal artery. You leave for the flap. You use the knife like this. See? You take just the fascia of the temporalis muscle. Okay? In the end, this fascia will be underneath. Because when you open the dura in the base of the temporal lobe, cut the tentorium and mobilize that, it's impossible to close watertight. Sometimes you need to cut the desygoma, sometimes you don't need, depending on the anatomy of the patient and the size of the temporalis muscle. If you have a huge temporalis muscle, you need to cut the zygoma to displace the temporalis muscle down. How you cut? As posterior as you can, as anterior as you can. Now you are putting first the mini plates, but do not remove the arch because the masseter muscle is underneath. Dissect it, try to preserve the fascia. Maybe the end, use this fascia to close the base. And do a very simple craniotomy in the temporal fossa. You have to go in the base to expose the whole base. In this anterior part, you use the drill, see, to have a large and deep flap, okay? And you are working under the brain. See, here's the base of the skull. You work in this direction. Now we are preparing to remove the Petrous apex. First, identify the medial artery. After you identify the medial, you cut the medial artery. You can cut some breeds, and now dissecting this direction from anterior to posterior, not to lateral to lateral. And peeling. Peeling is peeling, it's not cutting. And after that, you see a different bone. It's the cancellous bone from the Petrous apex. You identify the posterior part of the trigeminal nerve in Gacerium ganglion. This place anteriorly. I like to use this stitch and open this stitch like this. Now you start to remove the Petrous apex, identify the border of the Petrous apex. We know that the tentorial sign, the superior petrosal sinus will be in the border. How to drill? First, inside. Make a hole inside. You go from inside to outside until you reach the dura in the posterior fossa. You reach the dura in the posterior fossa. I like to open a little bit to take CSF. Now I'm using a different technique that I learned with Professor Sheeran. See, dura of the posterior fossa, dura of the middle fossa. What is in the middle? The tentorium. I need to open the tentorium to open the window. First we do, open the dura in the base of the middle fossa. Identify the tentorium. Okay? Go anterior there. See the border of the tentorium. Look for the fourth nerve. Here's the superior petrosal sinus. You coagulate and you cut. If you inject glue, never inject back. If you inject just anteriorly. That to go to the cavernous sinus. Don't inject posterior. Can go to the sigmoid sinus and transverse sinus. Before the last cut, where is the fourth nerve? Look for the fourth nerve. Can you see? You can do the last cut. Now you mobilize the tentorium back, the anterior part anteriorly. Now is the trick of the anterior protrusion. Open the portal trigeminalis, liberate the fifth nerve that is going to the posterior fossa. The tumor will be here, or here, or here. See, the fourth nerve is there. I can go to the posterior part of the cavernous sinus. If the tumor reaches the posterior part of the cavernous sinus, especially the Parkinson triangle, and if the tumor is coming from outside to inside, you can go and remove. But if the tumor is arising, especially meningioma, talk about the meningiomas, okay? The superior orbital fissure, in my hands, I cannot remove the tumor here without deficit. You can preserve the nerve, but the vascularization of the nerves here. But the tumor coming from the petroclival area or Petrous apex to the posterior part of the cavernous sinus, you can come and direct this. The people ask me, what's the trick to find the sixth nerve? You know, what's the trick? You find V1, find the root of the trigeminal nerve in this place. You find the carotid artery, you find the sixth. This will be filled by tumor. But you can mobilize the fourth, you can mobilize the third, you can hang here to see the posterior clinoid. You can remove the anterior clinoid. You can expose the optic nerve. You can go wherever you want. If you do larger craniotomy to the midline, you can go to the other side. The size of the craniotomy, you decide related to the disease, the size of the tumor. We have a case like this. Okay, you can come from the nose. Of course you can come from the nose. This is chordoma. You can come from the nose here. You can clean the tumor inside. You can remove this part here easily. You can come from the nose. But you also can come from below. But what is the most important point when you do chordoma or chondrosarcoma surgery? It's not removing the soft tumor. It's not to remove the tumor itself. It's to remove the bone that is in the border. If the bone is in the border, sometimes you have normal bone, sometimes you have islands of the tumor that is inside this normal bone that you cannot see. You have to remove the tumor, but also remove the bone. And you never is able to do a total removal of chordoma because some island of tumor there is inside the bone. See, you are doing the peeling of the middle fossa, just craniotomy, the basics that you learn in the residence, that you learn as a neurosurgeon, that you learn to do trauma, to do any kind of pathology. Now we're working extradurally. See, the tumors make the approach for me. The Petrous apex gone. The cavernous sinus is not invaded. The cavernous sinus is displaced. See, anterior and lateral. Here, great superficial petrosal nerve. Here's the dura in the posterior fossa. This is the part that's soft that I can remove easily with very short instruments and very stable hands. Oh, you can come from the nose, you can reach. Oh, you can come. You can come from the nose here. But this part is the posterior part. You can remove, maybe you can remove, but I need to remove this bone also lateral. The recurrence of the chordomas and chondrosarcomas are in the Petrous apex and condyles. Chordomas and chondrosarcomas, especially chordomas, in 90% of the case, we use the anterior approach, the transnasal approach, because chordomas are tumor from the midline, not from the lateral. In this situation, this tumor was more lateral. See, you can drill the bone, short instruments. You can see the dura that was opened by the tumor. We have our flaps that you rotate and close completely the cavity. In the pre and post-op, you rotate the muscle to close. You have situation like this, there is this bone invaded, can come from the nose. Okay, can come from the nose. But you also can come from the lateral. When you come from the lateral, you have this. Look the ICA. Control. Perfect control. Proximal and distal. You can drill medial to the artery. You can drill lateral to the artery and control. If you are coming from the anterior approach, it's very difficult to have proximal and distal control of the ICA. If the ICA bleed, you can pack and cry. If the middle fossa, if it is exposed of the ICA, if the ICA bleed, you can clip, you can suture, you can control. Safety is one word that you should use in surgery. Everything may be possible, but it's better, it's safer. This is question we should make to us. This question should make to us. You can reach every kind in the skull base from everywhere. But it's better, it's safer. It's the word that you should use. And the pre and post-op. This is the cholesterol granuloma. This is the trick that I learned with Professor Ike Shirian. He's giving a lecture about cysternostomy. And after that, he was showing me, if you open the cistern, the brain relaxes much better. This I'm doing now. See, I'm coming to the base of the frontal lobe, open the dura, go to the basal cistern, release CSF a lot, and the temporal bone relax. Much, much, much better than to put the lumbar drain. In end surgery, don't worry about pneumoencephalus, not worry about bleeding, subdural hematoma on the contralateral side. That can happen with lumbar drain. And then temporal lobe will relax. It's a great idea. See, now we're coming extradurally. See the temporal lobe. There is no temporal lobe here. Extradural, retract, and the Petrous apex here. We start to do the peeling. Peeling is peeling in this direction, anterior to posterior. Find the fifth nerve, displace the fifth nerve anteriorly. Here's the Petrous apex. Here's the cholesterol granuloma. I can wide the bone removal. I can expose the whole cavity. There are three ways, as Professor Gardner just showed, to treat the cholesterol granuloma. Two ways: you can drain by the ear infralabyrinthine or infracochlear approach, by the nose that you can also drain and put to drain. But I think that your mucosa, you come over the silicone drain, may be close. And there is one approach, it's from the middle fossa, that you remove all this part, you remove all the structure, you remove all this membrane, see, and occlude the cavity. In this surgery, the endoscope, you can use the endoscope to see inside. Oh, sorry. Let's move again. 1 second. See, you can identify the ICA. You work lateral and medial to the ICA. You remove all the contents of the cholesterol granuloma. You can use in the endoscope to see if there is something. Sometimes there is a small hole in the dura. It's not uncommon. You know what's happened if you are doing by the nose, the cholesterol granuloma. If you have a small opening in the dura, your surgery gone. There is no more surgery because you need to leave the cavity open from the nose to drain. This is the physiopathology. When you come from the middle fossa, you obliterate the cavity, you put vascularized flap inside, and this way, there is no more cavity. It's different way. Can have recurrence? Of course can have. But is the way that you treat and disappear that cavity with vascularized flap. The post-op you have like this. See, you have this in the pre, in the post you have this. You put something inside. And look, our friend here, the temporal lobe. After I start to remove this CSF, temporal lobe now is our friend. But the anterior Petrous approach, the pathology that is suitable, I think designed for the anterior Petrous approach, is a trigeminal schwannoma. That Professor Arthur Goyle has the largest experience in the world. We are here just following the anatomy, following the fifth nerve, from outside to inside. I think the first paper, large series of trigeminal schwannoma was published by Professor Arthur Goyle. But in this case, you see, if I come extra dural, cut the medial meningeal artery, peeling of the posterior part of the middle fossa, find the fifth nerve, and just follow the nerve from outside to inside. We are doing an extra arachnoidal surgery and leave the arachnoid to the nerves. Oh, you can come here from the retrosig and remove. Okay, you can, but you will work between the nerves, between the vessels. Why you play around the nerves? You can leave, if I can leave them away from me. When you start to do this, you become a little bit more curious. Like Professor Gardner showed, very nice surgery, nice approach. His experience showed that he's doing many things from the nose that an average guy like me cannot do it. But if you see this case here, 99% of the people say, come retrosig. And I think that is right. Come retrosig. Follow the porus trigeminalis and follow the nerve to the middle fossa. But you work in the nerve. What we did in this situation, let's follow our idea. Let's follow the nerve. Let's follow the anatomy. We came from the middle fossa, cut the middle meningeal artery, we start to do the peeling of the middle fossa. Okay. Identify V3, identify the Garcerian ganglion. Here's V2, you see. Sometimes you can use glue, sometimes you put some Surgicel. Here's the Garcerian ganglion. You can take some CSF. You find the tumor in the middle fossa. Okay, that was coming this direction here. Was coming more anterior. Very small piece. The big piece of tumor is in the posterior fossa. Okay, you open the Garcerian ganglion. Now you continue the peeling. You widen the Petrous apex and remove more the Petrous apex area. The tumor already open for you. You identify the superior petrosal sinus. This patient put Surgicel inside the sinus. You liberate totally the 5. Okay? When you cut the tentorium, you liberate the 5, you can go to the posterior fossa. And you start to see, here's the fifth nerve. Part of the tumor was here, part of the tumor was here. This is, you see, you leave the vessels, you leave the nerves with the arachnoid. See, you start to do like a peeling an onion. You know onion? You go peeling. See? But be very careful. The onion can make you cry. You don't be very cautious with the nerves and the artery. See? The arachnoid here, the nerves here, some bleeding here, put a little bit of glue and stop. In our basilar, arachnoid, see the fourth nerve, see the arachnoid is fourth nerve, protect. The best way to protect some structure, be away, be far away. This is the 5, see, from the posterior fossa to the middle fossa, and the big window here. In the end, you rotate the fascia, you rotate the posterior part of the temporalis muscle and close the cavity. Is our friend in the post-op, immediate post-op. See? This is slide 6 here. Sometimes you look to the 6, it's paralyzed. This light here, but he will come back. He will come back. And the pre and post-op room. I'm not saying that you should do this case by middle fossa. I'm saying that if you follow the anatomy, if you understand the anatomy, you can do a safe surgery, extra arachnoidal surgery, leaving the arachnoid to the vessels and to the nerves. There is tumor like tentorial meningioma that is there, is in the Petrous apex, is in the tentorial, and go remove the tentorial and remove the Petrous. There is tumor that the people say, oh, this is cavernous sinus meningioma. It's impossible to remove. You remove this small piece here and leave this part for radial surgery. The people say that. But if you understand the anatomy, you see that this here is the Meckel's cave. The tumor is following the fifth nerve. You just follow the fifth nerve from the posterior fossa to the middle fossa through the Meckel's cave. And this tumor can be removed safely without need of radiation therapy in the post-op. Just following the anatomy. We have another situation like this. This patient had a tumor in the tentorial. This lady was doing exercise in the gym, wanna be a stronger lady, started to take some hormones, female hormone. What's happened? Become very strong, and the meningioma start to grow, have a symptomatic. But the tumor is not just this ball here. The tumor, you have this tentorium edge. You should remove the tail, not only the small ball. When you do approach that you are removing just the small ball, you are doing just a partial removal. The recurrence is a matter of time. The tumor is here, okay? The tentorium. Can come from the posterior fossa? Of course you can come. But it's not the way you do it. This is the same surgery. You give this stitch in the meningo-orbital band. You go there, take a lot of CSF, release, relax the temporal lobe. You see, no spatula, no retraction, just took CSF, and then temporal lobe disappeared of your field. Now you can use the glue, do the peeling of the middle. It's the normal cavernous sinus, you know? It's bleed. Have to go inside the structure. It's the great superficial petrosal nerve, it's V3, it's the Petrous apex. This video is published in the operative nerve surgery in 3D. 3D. Use 3D glasses, you can see the depth. It's very nice. See? It's a long video. Go inside the Petrous apex, drill the Petrous apex, posterior fossa dura, middle fossa dura. What is in the middle? The tentorium. Oh my God. Sorry. Okay, come here. Oh, sorry. I'm sorry. Okay. Maybe it's time to finish. Here's the tentorium. Okay. You cut the tentorium there. See the dura in the posterior fossa. You open the dura in the posterior fossa. Take some CSF leak. CSF, not CSF leak. Avoid CSF leak. Okay. Identify the 5 in the posterior fossa that is displaced inferiorly. See the 5 there? We appear here. Okay. Here's the 5. The tumor is in the middle. I can remove in one piece the tumor and his attachment. It's attachment. The tumor attachment in the tentorium. You cut the tentorium as posterior as you can. You displace anteriorly. You find the border of the tentorium. You see the fourth. You see the incisura. You remove the tumor and the dura of the tentorium in one piece. Keep the arachnoid to the vessel. Keep the arachnoid to the nerve. You see the fifth nerve is going up. The third nerve will go anteriorly. You open totally the portum trigeminalis. You liberate there. See here? This is dura of the tentorium. But it is future tumor. You should remove this dura also. This is the 5, the third here, the 4th will be just here, or the 4th, very small. See the 4 here? The 4 like to, see the basilar artery? You see the 5 here. In the 3D, you can see the depth. The 5 coming from the posterior fossa and going to the middle fossa. You go to remove this part of the dura here in the posterior part. See, when it starts to bleed, you stop. It means that you are in the cavernous side. See, you coagulate this. Now we are using fluorescein. See if there is some enhancement here. And follow this. To bleed, you put some there. This is the 4th, 5th. This is glue, you know. I inject too much glue in this situation, and the glue come out. Looks like tumor, but it's glue. See? It was more difficult to remove the glue than remove the tumor. The 3rd, the 4th, the 5th, the posterior cerebral. Oh my God. Let's finish here if the lady. I want to show you this. Look the temporal lobe. Nice, you know? You can see. Pathology is in here is Our Lady. The preservation of oculomotor function. See? Same situation, same surgery, same approach. Difference in this case, the 5th nerve was completely displaced down. You come this here, you see do the same situation. We are holding the temporal lobe here, see? Pushing a little bit more than I should. See? The basilar. What gives me the approach? What gives me the view? The tumor and removal of the remaining Petrous apex. Okay? You put some glue, the post-op. Look the guy here in the oculomotor function preserved, and this is the hood that we are using to reach the area. Extradural to intradural. Arachnoid to the vessels, arachnoid to the nerve. Skull-based surgery straining. Straining from the nose, straining from the head, straining from the spine. If you don't do training in the laboratory, if you don't go to the anatomy department, if you don't go to the cadaveric discussion, never you learn the real skull base. Don't learn in the patient. Learn in the lab. Is the best way to do skull base surgery. Thank you very, very much. I'm sorry for the long time. I think I spoke more than I should. I appreciate your invitation. Now it's 2 p.m. Brazilian time. Thank you. Thank you very much.
Thank you, Professor Borba. You're really spellbound by your lecture. I'm sure Professor Aip and Professor Atul Goyal will have a lot of questions on this.
Atul is my mentor. He's older than us, you know. He's looking
Okay.
60, but he's almost 70 now. Yeah. Okay.
Hey, Luis. Good to see you.
Okay.
Excellent
Okay.
lecture. Excellent lecture.
Thank you. Thank you. Thank you. Who? Waking. Where is
Paul.
Atul?
Paul, Professor Atul, they might have some questions. Sanford, Paul, Professor Atul, all of them are here.
I think even Roman was also there. Roman Bochniak was there.
Yeah, Roman is there, my good friend Roman. Do you have some questions? Would you like to clarify some points?
Yeah, I think one of, as Paul Gardner, I think one of the main things that all of us are trying to understand, and it will be different for everybody, is what are the limitations of each approach. And I try to study that by looking at, tumor residual. But I guess I would ask Dr. Borba what he sees are the limitations or the areas that he struggles to access through an anterior transpetrosal approach. For example, are there portions of the clivus or the petroclival junction that are more difficult to visualize through that approach? Or what are the areas that that he struggles with that are complementary approaches between the two?
Yeah, for the intradural lesion, like meningioma, see, the limitation will be the internal thorameatus. The tumor go down there, you cannot see the. And for extradural lesions, for example, if the tumor is in the clivus, I don't go for the anterior petrous. I go for the nose. From the nose, you can see the whole clivus in front of you. The whole front of you. Because you cannot see from the anterior petrous approach, the clivus, you see one piece, one side only. You cannot see the other side. See, because in our book of chordoma, there is the chapter 13. You said the 10 rules of chordoma surgery. One of them, you always say to the patient that maybe you need more than one approach. For chordomas, we always start from the midline. See, because to see the whole clivus in front of you, if you cannot see from the anterior petrous approach the whole clivus, you see just a half. If there is remaining tumor in the petrous apex that I couldn't remove from here, I come to the anterior petrous approach. I think there is no competition. I think there is the tumor you should go to this way, tumor you should go to another way. You clarify very well when the case that you show that the whole clivus are there, the tumors are in front of you, you remove in front of you. But the anterior petrous is when the tumor is more lateral, not in the midline. Midline is not a good option for the anterior petrous approach. I don't know if I clarify.
No, it doesn't. I think that is probably the most important take-home point, is that the approaches are complementary, and trying to understand which areas are better accessed. And I think these videos showed beautifully today how the Petrous apex is just unparalleled through an anterior petrosectomy access. So I think that's the trick we're all trying to figure out, is where is that middle ground that and where is that crossover between the approaches?
Yeah. I see Mauricio here. Mauricio is trying to talk there. John, should turn on the microphone of Mauricio.
Go ahead, Mauricio. Let's see.
His microphone is off.
Yeah, I can't turn it on. I'm trying, but.
Now it's.
Yes, we can hear now.
Yeah, that's good.
Hi, Luis. I know Paul and all Hip and all our my friend, and I already know your answer, but I have to ask you, what do you is in your philosophy, or sometime are you planning an approach, but just thinking to a second step from the nose, or with another endoscopic approach?
It's for me.
Yeah.
For me.
Yeah.
I'll tell you something. There is no competition, you know?
Oh, of course.
If the tumor is centered in the middle, I go for the middle. I come from here. If the center of the tumor is in the side, I go for the side. The other day I did a case. I came from the nose. I couldn't remove. See, it was a craniopharyngioma. I couldn't remove totally. I came from the head. In the same day, I came from the nose again to put the pack and do the flap and put the flap back in position. You know? There is situation that you need to do more than one approach, because this is very important to talk with the patient. For chordomas, for example, we know that the best chance or the only chance that the patient has is to clean the MRI. If you need one surgery, two surgery, three surgery to clean the MRI, you should do it. See, I think there is case, for example, if you come from the Petrous apex, if there is tumor that remain in the clivus, maybe you should go and there remove. One point that Dr. Omefti is saying that I'm looking now, we have some tumors, some chondrosarcomas and some chordomas that, chordomas, great majority is in the midline, but sometimes is lateral. That we did the surgery from the side and the clivus looks normal. And the recurrence came in the clivus. I'm not sure, but maybe a crazy idea, no. In the future, not so far, maybe we should go to remove the clivus in every patient with chordoma. Since in the case that the tumor is lateral, the tumor is here, but the clivus, the origin of the tumor is there. And that island of the tumors that you see in the pathology are there in the clivus. You know? See, my philosophy is not to be the man of one approach. I see, I do this forever. I am the man.
This was the question. Of course, every one of us loves some approach and have experience, as you mentioned, our Chinese colleague after 1,000 modern 1,000 petroclival meningioma, he feel that the transpetrosal approach is the best. I have to trust him. But my question was, beside take a very long operation and just to manipulate sometimes, I agree with you. We have to have experience with almost all the possible strategy, all the possible. There is not competition between endoscopy, transpetrosal approach, open surgery, of course. The question was if sometime, in order to avoid a very long operation, a big manipulation, that sometimes you don't have the right working angle, just leave some piece. I know that leave some piece of tumor is something that is not in our philosophy as a surgeon. But if it is very difficult to have a better working angle or take a very long operation, just think about a second step from another angle.
I think time is not the problem. Long time is not the problem. Sometimes it's not safer. It's not safe. We are doing one approach. There is one piece that's not safe to remove from here. You leave and come with another approach.
Can I show a case and see, Dr. Borba, how you would approach this if you think there's one approach that could resect this tumor, or if you think it would require multiple approaches?
Great.
This is a case I did recently that I struggled very much to advise her what I think is the right approach. The tumor goes down just to the IAC. You can see it here, it goes to the midclavius, but it also has this very heavily calcified central portion to it. The sixth nerve, it turned out, was running right through this heavily calcified portion, which also extends into the cavernous sinus. But the tumor also involves the clivus, and it even has a nodule going here towards the right side of the clivus. So I'm curious what approach how would you approach this, or if you think it could be done in one approach.
It was a meningioma, no?
Meningioma, yes.
Yeah. I think the anterior petrous approach, you can reach this. I think you can reach, but you do have to remove a lot the petrous apex, the maximum that you can see, and work it. I think you could reach. This case is suitable for the anterior petrous approach. The problem here is sometimes the calcification is going around the nerve.
Yeah.
In this situation, is not the approach the problem. The approach is the situation. For example, the meningioma, the great majority of the time, is not the approach the problem. The problem is the plane with the brainstem. If you have a T2 with edema, like PIA invasion, independent of the approach that you do, if you try to remove, you have problem. See? I think the approach is not the problem here. The problem would be this very calcified lesion around the nerves. It's more difficult. But I think for the anterior petrous approach, if you do peeling of the middle fossa, you can remove this. You came from the nose, you came from the side.
Well, I didn't think that either approach could remove all of the tumor, because I thought that this part here, almost certainly some of it is medial to 6, and it involves the clivus. And so I thought that reaching this clival portion and the part medial to the cavernous sinus was going to be impossible. And so I offered her a transpetrosal approach as the first option, but she wanted to do endonasal. She came to me for that, and so that's why I ended up doing. But I left tumor lateral to the 6th nerve. So here is the course of the 6th nerve, and that was my limitation. But I think from an open approach, medial to the 6th nerve would have been a limitation also. And so I told her even up front that I thought she would need 2 surgeries, and I could do 2/3 of it from either approach. And so she wanted to wait for craniotomy, but I think she's going to need both.
Yeah, the calcification is not in the bone of the skull base. The calcification is in the dura.
Yeah.
It's intradural, this calcification. Sometimes you can remove easily, sometimes you cannot. But you know what's the most important, Paul? It's not the approach that you use. The most important is the philosophy to remove the meningioma. See? Go there and try to remove the maximum that you can. It's the most important thing. Because today, what the people are doing, they bite a little bit and send to radiation. The most important in this case is that your philosophy to remove the tumor. See? This you should teach the young generation or the generation that's there. That the way to treat meningioma is removal. Yeah. Wonderful. Okay, very nice, very nice.
That's the most important concept. Not because we have not to consider radiosurgery, because I have lots of friends in doing a very challenging case with radiosurgery. But in planning the approach, we have to approach the tumor with the mentality, with the philosophy to remove all the tumor in 1 step, in 2 steps, every time. Radiosurgery still remain a complementary treatment. In some cases, it could be the primary treatment, but very limited cases. Unless it's not safe, or as you said, there is calcification, that, as Paul said, the tumor around the sixth nerve. Of course, in that case, you have to leave the tumor and planning a second operation or send to the radiosurgery, but not, as you said, make an approach just by the tumor. Okay, then the rest of the job is belongs to the radiosurgery. That's not true. It's not a good message.
Okay, there is a very good carry home
90%
message. I think Professor Roman was about to ask something. Professor Roman Bojnik was about to ask something.
Yes, thank you. So maybe here we didn't say, we always approach to the Petrous apex bar anterolateral side from pterional approach by peeling dura, going over third nerve, V3, and so on, and start drilling. But we maybe didn't stress that it is also possible to approach purely subtemporally. So you mean with a small trepanation here just over the base of the zygoma, and then you do drilling like we do with the EMT in this approach for the acoustic canal. So this is the posterior border of this extended approach we can use, and we can work to the petroclival meningioma in more lateral or even half post lateral direction. So this is maybe less invasive approach. Maybe there is less temporal lobe squeezing with the epidural phase, and you can equally drill off the Petrous apex back to the acoustic canal, and you have a fine direction to the petroclival angle with more lateral or posterolateral aspect. So this, I would like to add that it's also possible to approach pure subtemporal. And here at the V3, you can also start to separate the dura lift and make things little more relaxed and easier to release the dura even easier. So this is the point I would like to add. So I can show maybe one case if you there. I don't know if you can see this one. This is the case I used pure lateral approach. I'm just asking you if you are seeing this screen.
No, you're not sharing.
How should I do this?
Just go to share content.
Yeah, okay. I don't know if you see something or no. You don't see my screen.
Not yet. Not yet. Keep trying.
Okay. Now?
Not yet.
Not
Are you
yet.
Are you clicking the share button at the bottom?
Yeah, I see the green one.
Yeah. Yeah.
Yeah, but
Try that again.
somehow it doesn't work. Because I have just one nice picture of
Well,
the approach. I used pure subtemporal to petroclival meningioma.
okay, we may have to consider an alternate
Yeah.
route of action now.
But what's about
There
now?
you go. There you go.
Oh, good. So this is the case, and I used here the pure subtemporal approach this way. And we also cut the tentorium, find the fourth nerve, and we also opened the porus. So maybe I will be able to show the so I don't know how to share the second picture, which is a control scan. I don't know how to share the second screen. I'm still trying. Okay. Well, maybe now, and this is the control
There we
scheme.
go. There we go.
Yeah.
There we go.
Okay, I make it. So here you see this small trepanation about 3.5 centimeters. And we do this at the base of the zygomatica, 2/3 front, 1/3 behind. And then we start drilling here. And first we try to find the possible acoustic canal by using the Ibanez-Garcia angle, which is between great petrosal nerve and 60 degrees toward the margin of the pyramid. And we will start drilling from here to the porus. So all this rhomboid fossa can be drilled out, and procedure is completely the same. When you find the fourth nerve, you did everything. So the sixth is next. So this is the only thing I would like to stress, that we can also use the anterior apex, this petrosectomy, also by subtemporal approach with a similar result, and maybe less temporal lobe mobilization. This is my remarks.
Okay,
Thanks.
great. Thank you, Roman. If there are no other remarks, then maybe we can conclude this session. It's been a fantastic session with all the stars here, starting from Paul, Louis, Roman, Professor Goel, and many more, Sanford. Everybody has been here. So thank you so much. Over to Vinod. Maybe we should conclude.
Thank you, sir. As you mentioned, it was excellent lecture by all the speakers, and all of them really rocked. It was a great show, and I would like to thank them once again for these fantastic lectures and all the attendees for attending the lecture. And our next section is on 20th September on CP angle and internal aortic meatus. We again have the lectures on endoscopic, translab, and retrosigmoid. We will update you all back again regarding the speakers of this session. As of now, we have Professor Daniel Marscioni from Italy speaking on the endoscopic approach. Professor I will be there on retrosigmoid, Borba, and I'll update you regarding this in a couple of weeks. So thank you once again for being with us. And thank you, John Bennett, for this neurosurgical TV. I'm sure he'll put up the recorded session very soon in the Facebook and WhatsApp. So thank you once again.
Okay, the edits will be ready soon. Thanks, everybody.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Professor Goel, thank you.
Okay, we're off the air.
Bye.